Hi, everyone. My name is Kendra Lodewick, and I have 3 kids with type 1. And for the purposes of today's call, I'll share they were ages 5, 8, and 4, respectively, when they were diagnosed. And I think that because camp serves kids once they get to sort of be school age, there's a lot of need for kind of community resources, solidarity among families with kids who are younger and are not yet at camp. And so we're hoping that we can provide some of that community here with you, and are really excited to have Kara here to share her knowledge and her experience with you. So if you want to take some time to introduce yourself and then kind of dive in.
Hi, everyone. Thanks for being here tonight, and thanks to the GCC team and Hope-Mongering for inviting me to join. I've never joined one of these meetings, but I've gotten the emails, and I just think it's a really fabulous place for families to find support, which is so greatly needed. I am a pediatric endocrinologist. I work at OHSU, Doernbecher Children's Hospital, and I have been in the field now for a little over 10 years. I was born in Wisconsin, moved around a lot, but spent most of my growing up years in Nicaragua, and then came back to the US for college and then medical school in Texas, and then came here for residency and landed in Portland and thought that I would be here for just a short period of time. And my initial plan was to do general pediatrics and then move on and move along, but really fell in love with Portland and discovered that I loved pediatric endocrinology when I was in my residency. And part of that, now that I reflect back, I've always been interested in hormones and endocrine topics. It was my favorite subjects in college and in medical school, but I never could envision myself as a diabetes doctor. I knew I wanted to be a pediatrician, but I didn't know, and I knew that endocrinology was largely diabetes. So it wasn't until I actually had that clinical exposure as a second-year resident that in diabetes clinic, to see how valuable it is to be a part of a young person and their family's life as they grow up with diabetes. I had and have great role models in the faculty at OHSU, and just fell in love with it. So quickly decided I want to do a fellowship, stayed for fellowship, and then stayed on as faculty. And it's been a really amazing experience and great joy. One of the best parts of my job is getting to develop relationships with families as kids are growing older. And I take care of kids and with diabetes, other endocrine disorders, so a wide variety of diagnoses, but diabetes is one of those where the closeness that I get to experience with the family is very, very unique. And I really do feel like I get to be part of the family. So I have at least 5, maybe over 5 patients who I've been following since they were in elementary school, who are now graduating from high school this year and going, all kinds of plans for going to college or starting apprenticeships. And it's just incredible to be at this point. And I feel like this is the year that I've had the most of my patients that I've been following the longest, that are now moving along to their post high school lives. And so just been reflecting on that. But I know that this is about the young ones, and I've had so many patients that I had the pleasure of starting to care for when they were diagnosed in their infancy or toddler years, or early elementary. And I mean, those are the ones that I get to know the best, because it's a really intense period of time at the time of diagnosis. I really value that relationship and getting to be a part of that process in the beginning, and then getting to have that experience of many, many years of building that relationship. So, my goals tonight are to first try to share a little bit of what I've learned along the way in terms of some specific ideas and strategies around coping with a young one with type 1 diabetes, and then some practical tips and ideas, but then also learning from you all, because that's how I get better, is knowing and learning what has worked for you and your experience. What do you feel that we as a medical team and community could have done better and should be doing better, and specifically for this population? So I do want to make sure that we have plenty of time for discussion and questions, and so happy to be here. So I was asked to come up with three kind of takeaway ideas or general topics for this specific question and population. And so I spent a good deal of time brainstorming about reflecting on my experiences, brainstorming, checking in with some of my colleagues, because we all have young patients with diabetes, and it can be a really challenging population. It's a challenging age for managing diabetes, and we're always sharing strategies and ideas with each other. So some of this I have to give credit to my peds endo colleagues at OHSU as well for contributing. The first is just kind of reflecting on the amount of stress and guilt that can be present at the time of diagnosis. And in my experience, that's always present regardless of the age of the child, but has seemed a lot more intense for those families for whom the diagnosis comes when they're in the toddler or early elementary age or infancy. And I think a lot of that is because, I should have mentioned, I'm a parent. I have 2 elementary school children who do not have type 1 diabetes. I don't have any family members with type 1 diabetes, so I don't have that lived experience. But again, really appreciate being sort of welcomed into my patients' families. But I am a parent, so just knowing, at those ages, their entire everything is our responsibility. It's, we create their world for them. There's really no outside influences. And so it's understandable that when something like this could happen, there could be a lot of feelings of, I did something wrong. I didn't do something right. I gave them the wrong things to eat, or didn't give them enough of this. What are the things that I exposed them to in early infancy that predispose them to this happening at this age? Or what are the things that I should have not exposed them to? Or what are the things I should have done differently? And I find it important to be able to listen to those concerns and those feelings, but also to provide reassurance that there isn't anything that they've done wrong. There's nothing they could have done to prevent it. There's nothing that they did or didn't do that would have led to a different outcome, that their child was likely genetically programmed to develop type 1 diabetes, and that for reasons that we're still trying to understand, this is the time that it's presenting for your child, and that we are here as a team. You will have resources to turn to for support, and we have incredible technology for management now, a lot of experience in working with this population, and you won't be alone. So really trying to take away, and even though I know and recognize that the parent guilt is hard to kind of calm down, that's there. I think it's just part of being a parent. But I find that a really important thing to recognize. I've also experienced, I've also found a lot of families of young ones experiencing guilt around not recognizing the signs and symptoms earlier. And it's very common for toddlers to present in DKA at the time of diagnosis, because kids aren't potty trained. They're in diapers, they pee a lot, they drink a lot, they ask for water a lot, and their behaviors can be really variable. They can be really tired for a lot of different reasons. And so it's not like an older kid that is potty trained and then suddenly is not and starts bedwetting, or has a really increased fluid intake. And so it's very common to not pick up on the signs and symptoms until the condition has really progressed towards DKA. And I find it important to acknowledge the fear that DKA presents, but also providing reassurance that that as we go forward, it's very common that kids will never have an episode of DKA again. And so it's not like they have to live in fear that this is going to be a repeated experience for them. So, and then I just try to also normalize the fact that it's very difficult to pick up on the signs and symptoms in toddlers, and that's really common. So that's kind of my first basic takeaway. My second is kind of along the same lines or related, and part of the fact that these are the two. The next one is reducing stress as best as we can as caregivers. And part of the reason why I think that these are the two top things that I kind of came up with is, one, my father's a child psychologist, so I grew up with, and my mom was an early childhood educator, so I grew up with in kind of a behavioral psychology family, and recognizing the benefits of behavioral techniques. And then also just, we're so lucky, we have behavioral health, essentially psychology professionals on our team that I have learned a tremendous amount from, in terms of just kind of helping families and young ones with behaviors and strategies for reducing burnout and coping with stress and coping with different types of behaviors that emerge at different age points and developmental stages. So this is kind of my biggest one. I think it's important to acknowledge that we as medical providers see this as one of, if not the hardest diagnoses to manage as a parent. And part of it is because we know that it's chronic, it's lifelong. It's not like it's something like a cancer diagnosis that's really intense all up front and then is going to change as kids get older. Maybe kids going into remission. It's a marathon, and that can take a toll on a family. So and we see it as physicians. It's very hard, especially in this age group, to manage diabetes. And blood sugars are going to be all over the place, despite our best efforts as professionals and despite families' best efforts. No matter what they do and the strategy they employ and the technology they have available to them or they put in place, there's still going to be wide variability in blood sugars. That is just diabetes, and we know that there are still very good outcomes despite that. So I think that's an important thing to recognize too, is that a lot of the families I see are coming to clinic, they're like, blood sugars have been so high all the time. And then when they find out their A1C or their time in range, if they have a continuous glucose monitor and they're so surprised that it's lower than they were anticipating, I often point out that it's not abnormal to remember those high numbers. Those are going to stick in your mind as like, oh my gosh, I failed. I didn't calculate those carbs right. I didn't give the right dose. And stress out about those high numbers without recognizing that that high number is temporary, and then blood sugars come down. And that overall, we look at the overall control and trying to see the forest through the trees. So again, really trying to take a step back from those moment by moment, which can be really hard in all cases, and especially if someone's using a continuous glucose monitor, which is a fabulous tool. But I had a parent tell me, I feel like I'm living my life in 5-minute increments, because it's like constant, checking and what is happening now, what's happening now. So that can be really tricky to deal with. Good management doesn't mean perfection. It's, again, trying to establish behaviors, healthy behaviors and routines and attitudes around diabetes, and doing our very best that we can to achieve blood sugars in our target range over time. And knowing that doesn't mean we're going to always be in range. Another point around that is it's recognizing that your medical team is there to support you and answer questions, especially outside of clinic visits. That's why we're there. That's why we have on-call providers. We anticipate and expect that families are going to reach out in between clinic visits, with even any questions are not considered simple or silly. We really value families who take a proactive approach and want to understand what are the patterns and how to interpret them, and what are things that they can be thinking about doing differently to try to achieve whatever goal is in place. And so if that means, sending messages back and forth with the provider to share ideas and thoughts, that's what we love to do. And it really helps too to have those points of contact in between clinic appointments. That being said, obviously, if things are going fine and you don't have any questions in between clinic appointments, that's fine too. Another thing, a few things that I've learned from my behavioral health colleagues is how important and valuable it is to try as hard as it is to remove emotions from numbers and not attaching emotions to numbers, blood sugar numbers, and really trying to keep in mind that a blood sugar number is a number. It's not bad or good. We often we'll use the words high or out of target or low, but we really as providers try to not use words bad, good. There's no bad A1C, there's no good A1C. And same with blood sugars, that they are information that tell us if somebody needs more insulin or less insulin, or if we need to think about the way different foods or activities are impacting their blood sugars. It's data, it's just information. And as parents, by finding ways to do that, to remove emotions from numbers, that has an impact on the child. And that can be really important as they're getting older and becoming more independent. Being able to have them be able to, know and share that there's no number that's going to say that they're doing something wrong or something bad. That's just information. The other thing, especially, I was kind of reflecting on some of the behavioral strategies and techniques that I've learned about specific for toddlers. And a lot of this is just kind of basic parenting stuff, but we were just kind of reflecting before we started on the fact that some of these things we might have heard about or learned about as kind of basic parenting strategies and techniques, but maybe just haven't had the need or opportunity to really put them in place, or utilize the skills. But with having a toddler with type 1 diabetes, it's a necessity. And so that in some ways could potentially provide the benefit of the family developing some parenting and family techniques and strategies that they may have not otherwise known to use or known the benefits of, especially if they have other children. So just kind of reflecting on the fact that could be seen as a benefit of being faced with this with a young one. Some of the things that I've seen that work particularly well are establishing routines and expectations. And toddlers in particular really thrive on knowing what's going to happen next. And so if there's a routine in place and they know that I'm going to have the meals at this particular time, and I'm going to have my blood sugar checked, and I'm going to get my medicine, and then, or, I'm going to eat and get my medicine. It can lead to less struggles with behaviors, kind of going against or the battles around getting blood sugar checks and injections in, or insulin dosing, or other things, or feeding. So really trying to have those established routines, and so that the young person has their expectations of what's going to happen next. I've also found it to be really beneficial to involve them in decisions when developmentally appropriate. And just because toddlers, as they're getting older, they often struggle with feeling like they want control over situations, but they don't have control, or they're losing control. And when that happens, that's when some of the more defiant behaviors come out. And that's with anything with toddlers. But if we can involve them in decisions and making choices so that they feel that they have some control of over the situation, that increases the likelihood that they're going to be compliant with whatever we're wanting them to do. So one example is if a toddler is resistant to getting an injection, and that's a repeated behavior, trying to help them understand that there's negotiables and non-negotiables. The non-negotiable is you're going to get your medicine, and the negotiable thing is that you can help to decide who's going to give the injection and where you're going to get it, so that they feel like they have a little more, some agency over what's going to happen to them. And then providing reinforcement is incredibly helpful in all areas. But, in one example is they are, cooperate with an insulin dose, and then they get to put a star on a star chart. It's incredible how well that works, even if there isn't a tangible prize. But also I've had families use, especially for kids who want their injections in the same spot every time, using a picture, a body picture, a drawing of a body with the different shot site options, so that they can pick the ones and make sure that put a star on the one that they got this time, and make sure that they're covering all of their spots, so that they're rotating their sites. And then the last kind of things is just emphasizing the importance of self-care. And I mean, I know that we probably just hear that over and over, but it is super important and valuable. We can't do it all ourselves. And so building your team, using your team, finding a support network, handing off tasks when you can, so that you can take a break and step away and do the things that you need to recharge, I think is super, super important. And a lot of the parents that I've worked with have found therapy to be helpful, especially in the beginning, where they want an objective and outside person to be able to talk to about what's going on and any conflicts that they may be having with their partner or their other child, and strategies for working with their kids who don't have type 1. That kind of thing I think can be really helpful when access is available. The last thing I was just going to say is, and I'm happy to answer any questions about this, but technology is one of the most exciting things that is going on right now in the field of type 1 diabetes. Obviously, we want a cure, and that is continuing to be investigated. But until then, the advancements in technology that I have been able to witness in the relatively short period of time that I've been working with kids with type 1 is just incredibly remarkable, and is so exciting. And just to think that when I started as faculty, I don't think I had a single patient on a CGM. It was so new, and it was fairly unreliable. It was so hard to get to access. And now I would say probably over 75 or 80% of my patients, maybe even more, are able to access a continuous glucose monitor that completely can completely change the experience, and it can give a better sense of feeling more confidence and safety and understanding of what happens with diabetes. And then also with insulin pump therapy, I have a lot of families of toddlers who ask, how old does my kid have to be able to get a pump? And I say there's no age, there's no magic age. Pumps with toddlers are great. And there are a couple limitations. One being making sure that the pump is able to deliver the smallest amount of insulin that they need. So some of the pumps but this is getting better, limitations in what's the lowest amount of insulin that can be given and as a basal rate or in the background 24 hours a day. And then the other is just making sure that they are able to kind of keep it on and in place. But there's lots of strategies for making that happen. And there's a lot of really amazing features that pumps have that are far superior to the limitations that we have with insulin injections. Some of them being able to customize the background insulin, being able to be a little more accurate and have the bolus doses be a lot more fine-tuned and not being limited to half unit, 1 unit increments. And then also kind of taking some of the guesswork out, because the pumps are able to keep a record of what insulin has already been given for a prior meal. If you want to give more insulin for a snack or a meal an hour later, which is really helpful for some toddlers who like to snack or like to graze throughout the day. So I think technology is another piece that's a really important and valuable thing for the littles. But those are the things that I kind of had put together. And
thank you for that. That was really, really remarkable. I feel like it was such a great mix of sort of like big picture sort of like psychological, getting your arms around it, but also some practical tools and tips for real world scenarios, and that both of those really resonate. So I have some thoughts on my experience, and I know Rob can share some experience too. But before I do that, I would like to open up to the group to see if you have any questions or any comments about your own experiences, whether this resonates with sort of the kind of feedback that you've been getting, or if there's something that you have learned in these early diagnosis of littles that has been really helpful, that would be useful to share with the group. So I want to pause for a minute just to see if anyone wants to step in, if there's anything they want to say or anything they want to ask based on what we just heard before we keep talking.
So we're 1.5 years into diagnosis, not quite 5 years old, and still having, even with the CGM and an insulin pump, blood sugar reactions that are all over the place. And so many, I happen to be fortunate enough to be close enough where I can physically help take some of the pressure off at times. But I am often asked by family and friends, what can they do to help support? So for those of you who have been dealing with this, do you have any suggestions on how family and friends can help, especially those close by and those far away as well?
Well, I would say from my experience, first of all, I want to say, like, you always make me cry when you come on because of how engaged or invested you are in your family. I'm going to keep talking so I don't well up here, but it's amazing to see. And I would say the biggest thing, I have the benefit of having a mom who has type 1, who, like, she's had type 1 since before I was born. And so, but they live across the country, but they get it. So that is a real gift, because they're not, there's no judgment, there's no question. They also know how relentless it is. So even though we don't live proximate to them, when we are together, they help as much as they can. They were the only people for a long time that we would have very intermittent like nights out because they were kind of the people that we felt comfortable leaving them with. And I guess I'd say, and then we have my mother-in-law moved out here when our third child was diagnosed, because I think she was like, okay, 3 is like, that's the limit. Like now I think you need some backup. So, but that said, you know, it's a lot, it's overwhelming. And I think it can feel, when you're not in it on the day, even though she lives, you know, 2 blocks from us, it can feel overwhelming and you can be worried about making a mistake. I'd say the biggest thing from my experience, and I would love to hear other parents talk, is being supportive. I mean, obviously not, I don't think any parent or grandparent on here would do this, but like not being critical of decisions that parents are making, whether it's type 1 decisions or just whether it's decisions that are like really made out of kind of in response to like a blood sugar number or something like that, or just out of a feeling of, you know, parents maybe needing to react certain ways because of their own, you know, sense of needing, like sometimes they may seem like they're overreacting in terms of like not taking you up on going out for a date night or something like that, but just supporting meeting the parent wherever they're at. And I think the biggest thing was finding someone, and it could have been a grandparent. We didn't have anyone living near us at that time, but for us, we did find a family friends who were willing to get trained, and there was a babysitter boot camp type thing, for caregiver boot camp, so they could go to like 3 hours to just kind of learn the basics. And that was the family that we had a family that you could go to so that you could get a break and could have a night out. That was really helpful for us. I think an ongoing support is just being positive, just being outside of like actual caretaking. You will all learn as your young kids grow that having type 1 makes them like really incredible rock stars. Like our kids now, 2 of them are in college and 1 of them is in middle school. And our oldest has had type 1 now for 15 years. And it's unbelievable. Like I'm speechless when I talk about it, and I will start crying. So I'm not going to talk about it anymore, but I'm so amazed by the perseverance and resilience of people with type 1. And I think that some of those resiliency and just some of those rock star qualities that form in people with type 1 also can form in parents in an analogous way. And no one ever, you know, you never step back and tell yourself that, and no one ever necessarily tells you that yourself. But I'm going to tell you all that right now, because I know it's going to happen, that to pay attention to this in the way you are, I guarantee you're really great parents. And so I think even just getting that reinforcement when you feel like you're just holding it together and you feel like as hard as you try, the outcomes aren't what you're expecting them to be. It's important to get that kind of, just have that validation and know that you really are rock stars. So I think, I guess I just feel like there is something to be said for just having your team have your back, even when they can't do anything tangible for you. That makes a difference. So, and this is not so much for family. So one thing I think I'd say, like, get as educated as you can and be as supportive as you can. But this is like from the parents' perspective, is being okay with, or not being okay with, but letting the sort of the intent be, if you leave your child with someone else, letting it be that you're going for safety and not perfection, so that you can feel comfortable leaving them with their grandparents or friends, and know that they might run a little high, or you know that they know what to do in an emergency, so they're going to be safe, even if their numbers might not be quite the same as they would be if you were there, and know that that's going to be okay for 3 hours or however long it is going to go for a movie and dinner or an overnight or whatever it is, that that if you get the safety right, you can avoid catastrophe and still be and not have any long-standing impact. So that's just something that I think parents have to come around to, and sometimes that takes more time, because it is definitely a condition where it feels out of control, and the more out of control things feel, the more in control you want to be. So it can be hard to release that. So that can be challenging sometimes. Related to that about the numbers swinging, I want to say I really appreciate your comment about that when sometimes, especially when parents with young kids come in, they're surprised that the A1C or the time in range is better than they expected because they're used to seeing, the highs. And I will say that that is something that I think generally I like to think I've got a pretty good handle on where that's going to be at. And now that 2 of our kids are away, like halfway across the country in college. And so we do follow them on the Dex, but as a result, I'm trying to, we have an agreement with them, and really we follow them over during the night when there's a risk of going low, but our phone still, my phone still tells me when they're having highs. So I recognize, like, conceptually, that I'm hearing the highs all the time and I'm not paying attention to the rest of it. But I fell prey to that too when when our kids were home for break and they went for the endo appointment, and I was like, oh man, this is going to be the worst blood sugar since diagnosis, or A1C. I was like bracing myself, and it was like better than the summer. And I was like, so that's just proof that that's an easy mistake to have. That's an easy habit to have, and don't necessarily outgrow it, but it is good to remember that you're fixated on the extremes and there's a lot of middle ground that's happening, even though you get hung up on the highs or the lows.
So our understanding is that just the Dexcom is not that accurate when they're that little. Is that, or is it the placement, or?
I'll tell you what my thoughts are, and then, but I'm curious to know what others say as well. I haven't heard, or hasn't been my experience, that it's less accurate at younger ages. I do have some patients who have said that that they have frequent times when they're losing connection, or that they feel that, or that it's not accurate or lining up with their blood sugar on their meter, or that they're not lasting as long as they should. But I would say that that's not common. It's a less common situation. And so when I do hear that, I try to kind of troubleshoot to make sure that we're trying out different placements. And if we're struggling with connection on the arm, for example, is there a way to try a different area on the body to see if that makes a difference? I have found that mostly in my adolescent population, who kind of run higher blood sugars, but the higher they run, the more often they have issues with connection. But I haven't really had that experience of there being lower accuracy in the younger kids. But
I know that Dexcom's terrific about, replacing them and having a dialogue with them about that, but I don't know if they tried any troubleshooting. So, and I also know that hydration plays a big role too for him. If he's not staying hydrated, you can start to see a lot of bogus numbers. So thank you. Thank you.
Has your son had any rebellion with correcting low blood sugars?
Correcting low blood sugars? Yeah, I've had a little bit. He didn't want to take the honey usually, and he loves honey. I can give him some other things, but it takes a little bit more to get him to go up.
That's hilarious. That's what we do too, is honey sticks. It's because it's such an easy, like 4 grams per stick. You can stick it in their mouth for them when they don't want it.
And mine's a scoop. I do a teaspoon out of the jar, and this is what you get. And he absolutely loves it. At first, he was kind of afraid. What the hell are you giving me? But he actually really likes it a lot. Even if it's crystallized, he'll eat it.
Good.
Yeah, I'm hoping my grandson can get into something that will stop the poking of the fingers and automatic insulin.
Well, the closed loop systems will do that now. So if you are on all 3 of our kids happen to be on one of the closed loops, and so they're they're on the CGMs, which those are the ones you change every day, and that those which monitors their blood sugar in real time all the time, and that is communicating with the pump. And so it is like it is helping to either increase or decrease their basal rate, which if you're not using, so increase it's automating some of it. It's not like it's doing it all, because you still have to give yourself insulin when you eat carbs, but it's almost like, I think of it as like being on cruise control versus manually driving. So it may kind of take some of the background noise out, but you're still responsible for giving insulin when you eat, but it really moderates a lot of the other numbers, especially nighttime. It's our experience has been really amazing at night.
Yes, the 2 o'clocks or 2 a.m. checks are horrendous.
Well, if you ever have a CGM, you can link it to your phone, so you could actually just wake up, look at your phone, see how.
Since we're brand new at this, 3 months or almost 3 months into it, our first endocrinology appointment is coming up. What is it that we want to ask?
Fight your insurance for a Dexcom. Honestly, it's like second to insulin. It's so helpful, especially with the variety in her blood sugar swings are so drastic in a 12-hour period. Your insurance should really give you guys a Dexcom or a CGM of any kind. It will be life-changing.
I'm gonna say the same, and most insurances are covering it now. Sometimes the deductibles and copays apply, and can, the out-of-pocket costs can depend on that, but we're getting really good coverage with insurance now. And that's definitely something that I would recommend bringing up at your appointment.
I will do that. I feel bad for his little fingers.
Yeah.
I do think it's really good to do things manually at first, just to learn the game a little bit. So don't feel like you're behind the ball. And, every new technology also has its drawbacks as well. So it's all give and take. Well, also, and I'm just venting here, I apologize, but like, I really feel like the products aren't made for 1 or 2 year olds, and we were using products that weren't designed for babies.
Well, you're right.
Yeah, completely. I mean, I made a comment in the chat about the diluted insulin and how beneficial it is, especially, we've had a lot of infants with diabetes, and you can't, just like you all are saying, like half a unit will just tank their blood sugar. And so there's a way that pharmacies can dilute the insulin 10-to-1, but it's incredible how complicated it is. It ends up being with ordering and figuring out the dosing. And I wish there was a way that it was more streamlined and straightforward, so that we could give 1/10 of a unit.
Times my daughter's was diagnosed at 2. We had to do the half units. We had to do the dilute, everything that you're saying. I remember it's bringing back all of that. But it's, and you can be like, I wish there were these products, and that's true. I agree with you. I hated it, but I also you come to a point where you go, well, I'm going to do this. I'll figure this out. And there's many doses. Your doctor can help you figure out the doses. It's like 5 units per, pound or something, not pound, but we figured it out back. And it was like, now, because our daughter would just sometimes refuse, like, nope, I've had 2 juices and I can't have any more. And we're like, well, it's either that or we're going to the emergency room, like right now, and she doesn't know. She's like 2. She doesn't know what that means. But she does remember being in the emergency room, and that was awful for her. So like, then you just learn how to do it. And it was hard, but it's a phase. It goes away. Like this period where the only time you're in range, you're going way up or way down. That's a phase. The bodies get bigger. That's what I would like to leave everybody with, is you're going to get some sleep. You will, I promise. The roller coaster starts to like not be, you'll still get extremes, but the roller coaster isn't every day a crazy ride. It's not the first thing you think of every day when you wake up. Sometimes you forget. Like I remember the first time we were sitting around at a restaurant and we were like eating, and we were like, oh, did you do insulin? And everyone was like, oh my gosh, we forgot we have like diabetes in our family right now. It was just the weirdest thing, but it was like a moment of celebration. Like, okay, well, we're living with this now, and it's not like a giant crisis all the time. Anyway, that's all I wanted to say is I recognize it. It'll go away. It'll pass.
I wanted to add one thing too, which is, you know, we do feel like we're out the other end of the worst part of it. We're through
Which
the
is hilarious because our kid is too.
through the initial trauma of it all, and the wave of emotions, not just for the kid, but for the parents as well. And the thing I wanted to add is that our daughter, Rumi Jean, no one told her that she needed to act like a sick baby all the time. She is just flourishing, and that's been the best news of all. And yes, there are traumatic nights and traumatic times where she doesn't want the shots and all the things, but overall, she's just absolutely flourishing, and we couldn't be happier with the support we've gotten from the professional medical community, the other families that have been through this, and just wanted to say thank you to everyone. So
That's wonderful.